Hello friends, welcome to Knowledge Bytes. Friends, today we will see the detailed explanation of pharmacology of bronchial asthma. Friends, if we understand the pathogenesis of classical allergic asthma, then we can classify the drugs in easy way. So firstly we will see the pathogenesis. Suppose if a person is sensitized to foreign allergen, then what will happen? This is a mast cell. This mast cell has receptor, and this receptor is Fc epsilon R1. On this Fc epsilon R1 receptor, IgE antibody is attached. Now if the allergens again come to the bronchial region, then this allergen, which is now suspected as antigen, will combine to this IgE antibody. Because of that, reaction will occur, and this reaction will lead to breaking of this mast cell. And when this mast cell breaks, the chemicals which is present in this mast cells, they get liberated, and the chemicals are histamine, tryptase, prostaglandin D2, and the most potent, which is leukotriene. Leukotriene is most potent. This leukotriene acts on bronchial receptor and does bronchoconstriction. Bronchial asthma is due to type 1 hypersensitivity reaction because there is involvement of IgE antibody. Okay. Firstly, we will see the mechanism which is related to leukotriene. After that, we will see the role of histamine, tryptase, and prostaglandin D2. I think I am clear to you all with the pathogenesis. So, suppose if bronchoconstriction has occurred, then we want to reverse this bronchoconstriction. Then how can we reverse this bronchoconstriction? We can reverse this bronchoconstriction by giving bronchodilator. We can also reverse this bronchoconstriction just by giving bronchial receptor antagonist, so that leukotriene will not act upon bronchial receptor. So we can give bronchial receptor antagonist. We can also reverse this bronchoconstriction just by giving the drug which decreases the synthesis of this leukotriene. So we can give leukotriene antagonist. We can also give drug which stabilizes this mast cell so that none of the chemicals will be released. So we are giving mast cell stabilizer. We can give a drug which does not allow this antigen antibody reaction to occur. Antigen antibody reaction inhibitor. We can also give the drug which destroy this IgE antibody, that is antibody against IgE antibody. Antibody against IgE antibody. So starting with bronchodilators. Bronchodilators are sympathomimetics, antimuscarinic, that is parasympathetic inhibitor drugs, or we can give theophylline drug. We will see each of them one by one, starting with sympathomimetics. Sympathomimetics. Epinephrine was used before. Epinephrine was used, but this epinephrine causes bronchodilation. This epinephrine acts on receptor alpha, beta 1 and beta 2. It was having more side effects, and side effect was worsening of angina pectoris. Also, it causes arrhythmia. Then a better drug was now used, that was ephedrine. Ephedrine was good drug, but more better drug was now used. Now better drug was synthesized, which is beta 2 agonist drug. Beta 2 agonist drug is better than ephedrine. The beta 2 agonist drugs are short acting, long acting, ultra long acting. Short acting are albuterol, which is also known as salbutamol, terbutaline. These two drugs, they are fast acting and short acting. So these drugs can be given in acute attack of bronchial asthma. Now talking about long acting drugs. The long acting drugs are salmeterol, formoterol. Salmeterol is long acting and formoterol is long acting, but salmeterol is late acting and formoterol is fast acting. Salmeterol is late acting or slow acting. And long acting drugs or ultra long acting drugs are given in prophylaxis. But you can see this formoterol is fast acting, so it can be given in prophylaxis. As well as it is fast acting, so we can give in acute attack of bronchial asthma. Whereas salmeterol is long acting, so it can be given in prophylaxis, but it cannot be given in acute attack of bronchial asthma because salmeterol is slow acting. Now the drugs of ultra long acting beta 2 agonist drugs: endacaterol, olodaterol, vilanterol, bambuterol. These are ultra long acting drugs and they can be used in prophylaxis. But the drug of choice for acute attack of bronchial asthma, the drug of choice is albuterol. The other name of albuterol is salbutamol. Now we will see the mechanism of action of beta 2 drugs. Mechanism of action of beta 2 drugs. They causes activation of adenylyl cyclase. This activation of adenylyl cyclase causes synthesis of cyclic AMP. and this cyclic AMP is powerful bronchodilator. See here, synthesis of cyclic AMP is occurring when we are giving beta 2 drugs. Now I want to talk about this theophylline drug. Cyclic AMP, it gets destroyed by enzyme phosphodiesterase 4. Cyclic AMP gets destroyed. If we give this theophylline drug, it will inhibit the action of phosphodiesterase 4. Therefore, there will be increase in cyclic AMP. Now you can see the difference. Beta 2 drugs, they are causing synthesis of cyclic AMP, but their theophylline drug is not causing synthesis of cyclic AMP, but it is preventing destruction of cyclic AMP. I think I am clear to you all. But this theophylline drugs are not given because they are not given in bronchial asthma because of its side effects. It is having more side effects. So better drug to use is beta 2 agonist. Now we want to see the side effect of beta 2 agonist drug. The side effects are tachycardia, tremor, hypokalemia. Now one more group of drug which is left in bronchodilator group, that is antimuscarinic drugs. Now we will talk about this antimuscarinic drugs. Antimuscarinic drugs. Antimuscarinic drugs are drug of choice in acute attack of bronchial asthma with having coronary obstructive pulmonary disease. Antimuscarinic drugs are drug of choice in acute attack of bronchial asthma. I have told you, in only acute attack of bronchial asthma, drug of choice is salbutamol. But if coronary obstructive pulmonary disease is present, then drug of choice is antimuscarinic drug. So how coronary obstructive pulmonary disease occur? The most common cause of coronary obstructive pulmonary disease is smoking. Smoking leads to release of more amount of ACH, and this ACH causes spasm, bronchospasm. So we want to give such a drug which inhibit this ACH, acetylcholine, and the drug is atropine. We have developed more better drug than atropine, and the drug is ipratropium bromide and tiotropium bromide. Atropine inhibits the action of acetylcholine. Okay, because of that spasm, bronchial spasm is not occurring. So now we are cleared with the mechanism and we are cleared with the drugs, ipratropium bromide and tiotropium bromide. Ipratropium bromide is short acting and tiotropium bromide is long acting. So we are cleared with one of the group, that is the bronchodilator. Now if we get to know the synthesis of this leukotriene, then we can classify more drugs. Now we will see the synthesis of leukotriene. Leukotriene synthesis occurs because of phospholipid. This phospholipids gets converted to arachidonic acid by enzyme phospholipase A2. Now this arachidonic acid will get converted to leukotriene by enzyme lipooxygenase. This leukotriene will act on bronchial receptor and does bronchoconstriction. Now if we inhibit phospholipase A2, then the synthesis of leukotriene will decrease, or if we inhibit lipooxygenase, then also synthesis of leukotriene will decrease. So firstly we will see 5 phospholipase A2 inhibitor drugs. Phospholipase A2 inhibitor drugs are drug of choice for prophylaxis of bronchial asthma. Phospholipase A2 inhibitor drugs are beclomethasone, budesonide, flunisolide, mometasone, triamcinolone. These drugs are the phospholipase A2 drugs. All these are steroid. And which steroid it is? It is glucocorticoids. Therefore, glucocorticoids are the drug of choice for prophylaxis of bronchial asthma. I want to tell you the properties of steroid. The properties of steroid is it is anti-inflammatory. It also does not allow antigen-antibody reaction to occur. No antigen-antibody reaction will occur. It also decreases the inflammatory mediators. And I have told you the inflammatory mediators are histamine, tryptase, prostaglandin D2. So we can see the three functions of phospholipase A2. Firstly, it is inhibiting the synthesis of leukotriene. It is not allowing antigen-antibody reaction to occur. It is decreasing the inflammatory mediators. Now we will see the drugs which acts on bronchial receptor antagonist. The drug which act on bronchial receptor, they are montelukast and zafirlukast. These two act on bronchial receptor and does not allow leukotriene to combine on bronchial receptor. But these bronchial receptor antagonist drug, have a very rare side effect, and the rare side effect is Chag-Strauss syndrome. And Chag-Strauss syndrome itself causes bronchial asthma. So the bronchial asthma treating drug itself, its side effect is causing bronchial asthma. Now we have seen up till this much. We have cleared bronchoconstriction, bronchial receptor antagonist drug. Now what is left is the leukotriene drugs, mast cell stabilizer drugs, and IgE antibody against IgE antibody. So now we will see the lipooxygenase inhibitor drug. Leukotriene lipooxygenase inhibitor. Because of that, leukotriene formation will not occur. The drug is xylitol. Now we will see the mast cell stabilizer drug. The mast cell stabilizer drugs are sodium chromoglycate, glycolate, sodium chromoglycolate, and nidochromin. Only one group of drug which is left is antibody against IgE antibody, and the drug is omalizumab. It is monoclonal antibody. It is synthesized in mouse and then it is humanized. So we have completed this bronchial asthma. I think I am clear to you all. Omalizumab is an antibody against antibody. It combines to the segment of IgE antibody where it combines to the FC epsilon R1 segment of mast cell. Okay, so now we complete with the bronchial asthma.